everyone. I'm Marge Hutchison, the Director of Accreditation here at the IAC for Vascular Testing and Vein Center Division. Thank you for participating in today's webinar. Today we're going to talk specifically about quality improvement. Historically, in the past, you may recall we did these matrix types of things where true positive, true negative, those types of things. And then we advanced over the last few years to filling out the log only and not doing the matrix. And now today we're moving forward even beyond the log. All of the QI standards that you are familiar with are gone. They will be deleted along with the QI log. So these things are ancient history. We don't need to think anything more about those. And as of today, we're moving forward. Now, you can't have a better tomorrow if you're still thinking about yesterday. So forget about everything you've done for the past 20-plus years. Today's a new day. We're going to move forward, and we're going to start doing things in a fresh, hopefully better, improved way. So how does facility self-assessment improve the quality of patient care? Well, unfortunately, this is $1 million question. It's really hard to validate this type of thing. But what we're pretty sure about is that each individual person in any facility that performs any kind of healthcare procedures, you can personally make the difference, and you can personally improve the quality of the patient care. Now, everybody in your facility or your department could be doing less than good work, but if you personally are doing the best you can every single time you see a patient, that's making a difference, and that's improving the quality of the care. Now, a lot of people don't know how to do that, and so I'm going to tell you that you need to use the standards as your guide. Everything that will help you to improve your quality of care will be outlined in this document. You want to be absolutely certain that you're using the most currently published document, 8/3/2015. This is fresh on our website, and you're welcome to go in there. You can read it, you can download it, you can print it, do whatever you like. Just be sure that you are compliant to that within the next few months. Now, the biggest change in vascular testing is the Quality Improvement Program, as I mentioned earlier. The old program is going away, and the new program is coming. And you will see this in the standards. They will be highlighted in bright yellow, as all changes are. And you can read through them. I'm not going to read all the standards here for you specifically, but I am going to go through them. So hopefully you'll have a better understanding of the standards when you read them. Improving and maintaining quality in the vascular lab. So this is how we're going to move forward. We're going to employ and document continuous process improvement measures, and we're going to show improvement processes in your own facility, and you'll be able to benchmark how you're doing with all of the other facilities that are also applying and accredited. So this is a whole new world for us here as we start looking more at continuous improvement and documentation. All right. Now, when you read the standards, you may become a little bit overwhelmed. There's a lot of changes. Nothing is the same. There's a lot of new language as well. So we're going to go through this facility self-assessment program, and we're going to do it one step at a time. So don't feel as though it's so daunting that you can't get there, because we're going to do it just a little bit at a time, and you'll be very successful, I'm sure. Now, the new QI program requires facilities to do a self-assessment, and we are giving you 5 metrics that you must evaluate when you go through this process. And I'm going to detail these out a little bit, but the metrics are test appropriateness, technical quality of the imaging, interpretive quality review, report completeness and timeliness, and case review. Now, you may notice that we're focusing basically on what the part that affects the patient, the quality of the imaging, the quality of the interpretation, and the quality of the reporting. Because if those 3 are not in synchrony, then somebody is not going to have a very good quality experience. So all 3 have to be done. They have to be done very well. And if not, now's the time to figure out what needs to be fixed and how you're going to go about fixing it. So basically, this is what we're looking at: the technical quality, We're looking at the interpretation and your diagnostic criteria. And then, of course, the final report, because I think we all know that we can do excellent imaging, we can do excellent interpretation, but if there's an error in the final report, that's a problem. And the same is true for any one of these three things. If one is wrong and the other are good, it doesn't make for an overall good picture. So everything has to be aligned properly. So the first metric is called test appropriateness. Now, a lot of times people think just because they have a payable, a code that pays them, that makes it appropriate, and that is not the case. The case is, are you doing this procedure on this patient for the right reasons, the right time, those types of things? So it's not just about, can I get paid? Because you can get paid for doing a lot of procedures on the patient, but they may not be indicated. So that's the key here. And so when you look at this part when you're reviewing your own cases, you're going to ask yourself, was this test appropriate for this patient? And you're going to make the decision whether it was appropriate, whether it may be appropriate, or whether it's rarely appropriate to do the study on these particular patients. And these are all well-defined data, and you can find appropriate use criteria for vascular testing. There's actually 2 published documents. One deals with arterial, and one deals with other vascular, venous, and those types of things. So you'll want to download these from the internet. You want to review them. This will help you determine if you're doing cases for the appropriate reason. Now, not the indication, because we can create any kind of indication we want to match what we've done, but this is digging a little bit deeper and really evaluating the procedure that you're doing for the patient. Now, the next metric is technical performance of the examination. Now, I'm sure you can appreciate that you have to do good quality technical work. And the first thing we're going to talk about is waveform. Now, whether you're doing ultrasound waveforms or continuous wave Doppler waveforms or PVR waveforms, there's all criteria to make each one of these a good sample. And so you want to be sure that no matter what kind of waveform you're doing, you do the best kind you can, the best quality of a waveform you can. And these are things you need to look at. And when you're doing these self-evaluations, these self-assessments, you want to be honest with yourself, because this is how you improve your quality. So you really want to look at these very seriously and as objectively as possible. You want to be sure that you're doing proper angle correction. You need to be sure that your sample volume is placed in the correct spot in the vessel. You want to be sure that your angle is appropriate, and not only for Doppler, but for color as well. And you can see there's some examples here where just as you move the probe just ever so slightly, you can change the look of the waveform, and you can change the color flow. And certainly we all know this, that when you change the angle of the Doppler, that you can significantly vary the centimeters per second velocity. So you really want to be very careful about this type of procedure, because a lot of people don't take this as seriously as they should. They don't realize that the slightest little movement of the probe can significantly alter the outcome. And when you're looking at your cases for self-assessment, you want to look for a lot of different things. First of all, it has to be annotated properly. Many times people will put the first annotation up there for the first vessel, and they'll forget to change it until they change to the left side, or they may forget the whole time, and every single image will say right proximal CCA or something like that. You want to be absolutely certain that you have good, clean waveforms, good, clean envelopes there. You want to measure them at peak systolic velocity, and you want to do end diastolic velocity. Now, the criteria is written for those specifics, and so when we talk about end diastolic velocity, we don't talk about mid diastolic velocity. We talk about end, and so you want to be sure that those cursors are placed properly. You want to be sure that they're at the proper height. You don't want to over-exaggerate the velocity on those vessels. You also want to do systolic and diastolic measurements in the same waveform. You want to be sure that your angle is corrected. You want to be sure your color box is properly set and that your sample volume is correct. Remember, when you submit your cases to the IAC for review, we want you to keep all the demographics on there. We want to be sure that you're doing true patients, and we want to be sure that all the settings are proper. So you want to leave all those things on there. So you have to be really pretty objective when you're looking at your own cases. Now, it's critically important that the ultrasound images and the ultrasound report and interpretation tell a story, and you want it to be an accurate story so that if the patient goes on to further testing, they complement what you've done. And so, again, you want to be able to tell everything you can about that patient from your test results regarding the issue they're sent to see you for. Also, your study must include all the required documentation. Again, these are things that are in the standards. Everything's listed there. You can certainly do more, and in fact, if you find areas of unusual interest, you want to do extra documentation, but yet you must do at least the minimum that's required in the standards. And if you do that, it equals a quality case. Now, of course, you can always do more, but at least the minimum. Now, when we talk about physician interpretation, this is just as critical as the other piece. You can have a very well done technical case, but if it's not interpreted accurately, that becomes a problem. Now, when you have diagnostic criteria, it must be published, meaning that peers have done some evaluation of the work. It has to be validated, meaning that those people that are putting their name on that criteria have validated it for everything that they say is in that criteria. So you want to be sure that you're using criteria that is published and validated, and you can't mix these up. You can't take one that's published and validated over here and mix it with one over here and come up with your own criteria. You really have to pick which one fits your facility best, and you have to stick with it. No more hybrid kinds of processes. You really have to investigate and pick the one that works best for you. The most important part about this is the interpretation accurate? And you may be thinking to yourself, well, that's a little bit of a no-brainer because, of course, they are. But we experience a lot of cases here at the IAC where they're not accurate, and we highly encourage you to be sure when you send out a report that it says exactly what you think it should say and what you want it to say. We see many interpretation errors here, so you can ask yourself these questions when you're reviewing your own report. Is the interpretation off or not accurate because the exam is technically suboptimal? Or is the interpretation inaccurate because we did not adhere to our diagnostic criteria? Are there disparate findings in the final report? For instance, is this a right lower extremity exam and all of the findings say left, or the impression says left? Do the images support the interpretation? You certainly can't say, oh, the calf veins were all visualized and compressible, when for some reason you couldn't see the calf veins on that patient. So you have to be very careful with your medical records to be sure that the things you commonly click are true for each patient that you're doing it. And then, of course, does the final report incomplete findings? You cannot say, oh, the patient has calf DVT without saying that it propagates up to the popliteal or the femoral or whatever. So all of these things are things that we see every day, and it seems to be more of a common problem than it used to be. So I just encourage everybody to just really read your reports. You don't have to read every one of them. If you do a survey of some sort, I think you'll come to realize where your facility could improve its reporting. Now, the final report is the next metric that you're going to look at. Again, the standards will tell you exactly what needs to be in the final report. Obvious, we need demographics. We need to know who the patient is, the date of service, the date of birth, the referring physician, and whatever else you require in your facility requires. You have to have a description of the exam that you perform. So if you're doing B mode, color, spectral Doppler, or physiologic, or whatever, you have to spell that out, what you've actually done for the patient. You have to report pertinent positive and negative findings. If you do a bilateral study and one leg is totally abnormal and one leg is totally normal, you cannot forget to say that the right leg was normal. You have to report good and bad things. And don't forget at the bottom of that report, you have to have a summary where all the above paragraphs are combined into some very succinct language that tells the referring physician what the findings were. Those are all requirements. You find them in the standards, and you will find very good reporting data there. Now, in vascular testing, you also must report incidental findings. Now, you do not have to interpret what you see, but you have to report that you see it, what it looks like, how big it is, does it have color flow, does it have Doppler. So you don't exactly have to know what it is, but you do have to report what you saw and what you did to investigate that area. The final report, it must contain information so that any healthcare provider who is unfamiliar with this patient, but is a healthcare provider, so knowledgeable in the language, your report has to tell the story. It has everything you've done, and that less than vascular expert person must be able to understand what you've done and must be able to understand the results of the study. Now, just a reminder that your final report and all the data that you collect, all the images, all the data, these are legal documents. At any given time, they can be called from a lawyer or a court of law or something, and they will want your documents. So this is another good reason to evaluate your documents, to audit your documents, and make sure that they're honest and truthful and accurate. Remember that that final report has to tell a complete story. You can't leave out little details because that may be the most important detail in that patient's process. So you want to be complete and thorough and truthful and accurate. Now, you are, in addition to looking at those metrics, there's a fifth additional metric, and this is to help those people kind of convert over from the old to the new system, where you will still be looking at a couple of correlation cases, 2 cases per testing area, and a minimum of 4. So if you have a whole lot of testing areas, you'll meet that minimum without any problem. But if you only have 1 testing area, you have to do at least 4 cases. And you can look at angio, MR, CT, surgery, clinical outcomes. You can look at all kinds of different review processes. You can use whatever one you want, but you are still required to look at a little bit of correlation studies. So you want to be in the habit of doing that as well. Now, there are many things coming soon. The standards are being published August 3rd, 2015. We are working on some helpful tools for you. For instance, we will soon have a sample QI policy so that you will have an idea of what we're looking for. We'll have sample QI meeting minute templates because the minutes for the meeting have to be very specific now. You have to discuss the findings of these metrics that you've investigated. So you've looked at your cases, you've answered all the metric questions, and you have to evaluate those, and you have to think those through, and you have to discuss those at your meetings. We're also going to give you some electronic tools to make it easy so that everything is done online, and you won't have to be carrying your logs around and that kind of thing. And we will also give you interactive logs. So we're going to try and give you the tools to make this change a lot easier than you may anticipate it to be. So now that we've discussed all of this stuff and the standards are written and they're all out there, what are you going to do? How do you get started? What does all this mean to you? Well, the biggest difference is we have to move from quality assurance, which we're used to and have been doing for years now, which is the maintenance process. You have to move to quality improvement, which is looking at what you're doing and improving what you're doing. There's always room for improvement, But now you have to go look for it, and you've got to figure it out. You have to figure out what has to be improved, how you're going to go about it, how you're going to evaluate it, and then if you're going to actually adopt the changes. So the first thing I think you should do is, once you've read the standards, of course, is to create a new quality improvement policy that reflects the standards that will be a part of your facility. So you kind of have to have all the standards in there, but it has to be appropriate for your facility, your practice, whether you're a one-on-one practice or whether you're a big, huge hospital with 10, 15 staff, those types of things. So this is the first step, to create a new policy. Then I would suggest you start your reviews. Just decide to monthly pull a random set of cases. Don't pick special ones. Don't pick special testing areas. Just say, okay, today we're going to pick 6 cases, and we're going to review those cases. Now, when you're doing that, you want to keep track of what you're doing, because at some point we're going to ask you for some information on those cases that you've reviewed. So you want to keep a nice log, an Excel spreadsheet. I recommend you do it that way. And if you keep it in this pattern, you'll find it'll be less trouble, less cumbersome for you to transfer it to the electronic documents that we're going to give you. So might as well start off fresh, collect your cases this way. You don't have to do all of them in one day. I would say every month, pick a couple and look them over. Now, this is similar to one of the forms that we're going to give you. It lists all the metrics and the questions below it that will help you determine if you have met those metrics. And this is a little bit reflective of peer review, but it's much more detailed than peer review. So you don't just want to check the boxes off and say, yes, 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 everything was perfect, because we know that's not true. We all know that's not true. And so you want to be very objective and be critical of yourselves, because this is the only way you find out how you've done, how you're doing, and where you can improve. Now, you must have QI meetings, of course, and you must have 2 per year. That's not changed. All staff must attend. You must record the attendance, and you must keep very detailed minutes about what you've discussed, because now you're going to be required to discuss these QI metrics and these QI cases. And so you want to keep very detailed minutes, and you can assign somebody in the group to do that for you. These, most likely, you will have to submit these to us, so that will give you encouragement to do a full and complete recording of the minutes. We're probably going to want to look at these. And finally, if you have any questions about the QI project, or how you should begin, or what you should do, or if you read the standards and you just don't have any idea what the heck we're talking about, please call us, because we are the ones with the right answers. We want you to succeed. We want this to be a good project where you can learn something about your facility. You're doing it for yourselves. You're doing it to improve your own patient quality. So don't hesitate to call us or email us, and we will gladly help you understand what we're talking about. Keep your eye out on the website for those helpful documents and policies and samples that will come along. They are in the process of being created as we speak. So just keep your eye on the website for all the new things that are coming up. I think what you'll find as you move forward is that this is a very good self-reflection on what you're doing for your patients. Thank you for your time. I really appreciate your listening to this webinar, and I hope you have great success with the new QI program.